Hello, my name's Dr Joanna Feary. I'm an honorary respiratory consultant at Royal Brompton Hospital and clinical lead of the Occupational Lung Disease Service. I'm also a senior clinical research fellow at the NHLI at Imperial College London. And I'm going to be speaking to you today about artificial stone silicosis and the emerging epidemic it is presenting in the UK. So I'm going to start with a bit of background. Silica, or silicon dioxide, is a group 4 metal oxide. It is abundant in the Earth's crust and occurs in two main forms. The first is crystalline silica, or quartz, cristobalite and trimodite, and amorphous silica. It's abundant in products like sand, and so is ubiquitous across the Earth. Silica, when it is freshly cut, is known as freshly fractured silica, and the material that causes us problems in terms of respiratory health is known as respirable crystalline silica, or RCS. And this is silica which is freshly fractured or cut up and then becomes tiny particles which can penetrate deep into your airways, and so we call that respirable crystalline silica. Exposure to RCS is a global issue, with estimated 10 million individuals exposed in India, 2 million exposed in Brazil, and around about 50 million artisanal and small-scale miners globally working with RCS. These pictures on the right show pictures from a mine in Tanzania and a quarry in Rajasthan, where exposure to RCS will be very high. Around 2.6 million cases of silicosis are thought to exist globally, but these numbers are likely to be a significant underestimation. In the UK, we estimate that around 600,000 individuals are working with silica, but again, this is based on old data and may well be a significant underestimation. Who is at risk of exposure to RCS? Well, you can determine this by asking somebody about what they do for a job. Here is a list of different job titles that someone might give you that suggests that they will be at risk of RCS exposure. So stonemasons, kitchen fitters that we'll talk about a little bit later, people who work in quarries, people working with bricks, pottery workers, glass workers, sandblasters, foundry workers, miners, and dental technicians. And also a very large category are construction workers who work with products like cement and concrete. And this may include people who call themselves tunnellers, concrete workers and paviors. And once you've established that someone may be at risk of RCS exposure, the next thing to ask them is what materials they work with. So you can see from this table that there's a huge variation in the amount of silica contained in different stones. So if you go right to the bottom of this table, you can see that a stonemason who's only ever worked with marble or limestone will be exposed to very low amounts of silica because those stones contain less than 2% silica. Somewhere in the middle, you have products like granite, which contain around 30% silica. And then you increase up until we reach sandstone, which has got really high silica content at between 70 and 90%. Right at the top of this is engineered stone or artificial stone that we're going to talk about today, but this contains up to around about 95% silica. So when you cut engineered stone, up to 95% of the product that you're cutting contains silica, and people working with these products will therefore be exposed to very high levels of RCS. So what is engineered stone or artificial stone? It's known by a number of different names, and the people who work with it tend to call it quartz. It is a product that's largely used to make kitchen worktops, as you can see in these pictures. And it's made up of finely crushed rocks, so primarily quartz, but also cristobalite, bound together with polymer resins, pigments, and metal oxides like cobalt and aluminium. And these create an aesthetic product. So this product can be designed in an array of different colours and in an array of different patterns. And people like it not only for the aesthetic properties, but also because it's highly resilient. So it's non-porous, it's scratch resistant, it doesn't stain, and it's got high flexural strength. And because of the lack and absence of natural faults in the rock, it's very easy to process. You don't need much training to do so. And in addition, there's very little wastage because you don't need to cut round those natural faults. So it's a more cost-effective, cheaper product. And it's become increasingly popular over the last 30 years or so, since the late 1980s, but has probably been in the UK used on a regular basis only for about 15 years. The size of the engineered stone market is huge, and this is data from the US, where you can see it just starts in 2020, but was valued at around £25 billion recently, and is projected to increase to $37 billion dollars by 2030. In case you think it's just a problem in the US, here is a chart showing the growth of imports in pounds, and you can see those engineered materials in the dark blue line, in addition to ceramic products, really taking off, in contrast with granite, stone and slate down here. And the people who sell this say that the key factors driving the engineered stone market include the growing demand for aesthetically pleasing, low-cost alternatives to natural stones such as marble and granite. So this is all about consumer demand. So why is engineered stone causing a problem? So there are a number of properties that the product has which we think are driving this. The first, as I've already talked about, is the very high silica content. The second is the particle properties. So when you cut through engineered stone, the particles that are generated are ultra fine because they've already been ground up, and this means that they can penetrate deep into the lungs. We also think that the morphology, so the shape of the particles that are cut, are unusual. So in the bottom here, you can see natural stone particles compared with engineered stone under high resolution imaging. And the engineered stone have much greater surface area and therefore potentially a more irregular morphology and shape where the stone can interact with the lungs and cause an inflammatory process. And then finally, there may be issues related to other emissions produced during the fabrication, so during the cutting. And this includes things like emission of volatile organic compounds, or VOCs, like styrene, methyl methacrylate and phthalic anhydride. And these three VOCs are all known causes of occupational asthma. And so there may be some sorts of interactions between cutting the product and releasing not only RCS, but agents that can cause occupational asthma in that worker. I've already talked about the fact that it's easy to process and that you need very little training. And indeed, this means that people have started to fabricate it and cut it using things like an angle grinder in this photograph below. And this means that people can do it with very little training and without the engineering controls in process to try and control exposure to the RCS dust. And this is a experiment that was done in a workplace where they looked at the differences between the amount of silica generated using different processing techniques. So this is over 30 minutes and the amount of RCS or silica that was generated. So when you dry cut it, as shown in this photograph, 44 milligrams per cubic meter of RCS was generated. When you did the same process, but instead used water suppression, so sprayed water on top of the grinding wheel to damp down that dust, the level came down to around about 10%, so a really huge reduction. And when you then also used LEV, or local exhaust ventilation, to withdraw the dust, the level came down to 0.6 milligrams per cubic meter. So on paper, that looks very reassuring. However, just a reminder that the workplace exposure limit in the UK is that people shouldn't be exposed to RCS more than 0.1 milligrams per cubic meter. So that's 6 times higher than the workplace exposure limit. And indeed, this is the UK exposure limit, but in Australia it's 0.5 and in New Zealand it's 0.25. So the limit in the UK is already set higher than that elsewhere. So even with wet cutting and local exhaust ventilation, there's still a huge amount of RCS generated. But because it's easy to process, people are continuing to do that using just dry processing. So a little bit of terminology about how we talk about engineered stone. And this is sort of the life cycle of a kitchen worktop. So it starts off with stone manufacture. So this is photographs of a quarry in India. And then these stones are cut up and transferred to an artificial stone factory. So the stone is then crushed up before being moulded with the addition of these other agents, these polymers and resins. And these are moulded and then pressed into shape before, in the middle picture, being put into an oven to cure it. And then it comes out, and the slabs that it has generated are then polished before undergoing quality control. That's all the artificial stone manufacture. These then arrive in warehouses in slab form, like you can see here. The artificial stone manufacturing process at the moment is done only outside the UK. So what comes into the UK are these fully formed artificial stone slabs. They then go into a workshop where they undergo fabrication. And what we mean by fabrication is the process of cutting these slabs into the right sizes, and often using something like a CNC machine, which does the process automatically using computers to cut the slabs, and it may often be done in an enclosed process. Once these slabs are cut into shape, we need to do the finishing process, which is cutting out these these square holes, which is where the sinks go, the hobs go, and the tap holes go. These are two photographs which are posted with permission from a worktop fabricator which I visited. You can see in the photograph on the left, the polishing process is being done with a hand tool, so an angle grinder, hand polisher, but with the use of respiratory protection, so an air-powered respirator, which is protecting the worker from exposure to dust. And you can see that he's also wearing gloves there. In this photograph on the right, somebody is also doing the process, and this time is using water suppression, so you may be able to see some water on the floor, and the use of local exhaust ventilation to withdraw the dust from where he's polishing, and the water spray from where he's polishing, but he's not wearing respiratory protection. But unfortunately, because it is an easy process and people are doing it in workshops where there isn't good attention to health and safety because it's possible to do so, we have photographs like this. So this is a patient of mine who gave me this photograph from a workplace he worked in for a brief period of time. And you can see in this workplace, there's dust everywhere. There's dust in the air. You can see footprints on the floor. The worker is using an angle grinder. There's no water suppression. There's no local exhaust ventilation. And the only respiratory protection is a simple surgical face mask. So this is in breach of health and safety law, but is also exposing that worker to very high levels of RCS. And then once the fabrication process has taken part, then somebody will go with this worktop into the home to carry out the installation process. And a lot of the time, this doesn't actually involve any cutting or polishing, but in some cases will involve quite a lot of that, and it will vary from company to company. And this is a photograph of an installer from my clinic, and you can see that he's covered in stone dust, and you can imagine as well that his face will be, and he's not wearing any respiratory protection. So installers will in some cases have very high levels of exposure as well. So due to this exposure to very high levels of RCS from artificial stone, we now have emergence of a global epidemic. And silicosis due to artificial stone was first reported from a Spanish group in 2010 when they reported 3 cases in kitchen worktop fitters. This was followed by a number of different case series, including this one from Israel, which was from 25 cases referred for lung transplantation had silicosis due to artificial stone manufacture and installation. There have now been case reports from 12 different countries across the globe, and you can see here really how things started to evolve. So Italy and Spain, followed by Israel, the US, Australia, China, Belgium, and then more recently the UK. And we had been saying that we thought there were around about 1,000 cases, but a recent review is being undertaken by the American Thoracic Society, and we think there are now over 4,500 cases of artificial stone silicosis that we know about, and this will be an underestimation of the true size of the problem. So these are the epidemic curves. They're all based on slightly different data, but will show you the sorts of changes that we're seeing in the number of cases identified. So here is Spain, number of cases of silicosis due to which were reported due to different agents. And what you can see is that rapid increase from round about 2009, and this is largely due to artificial stone. Israel had cases reported of silicosis amongst lung transplant candidates, and this just finished in 2010, but you can see that big peak there, which is related to artificial stone production. Here it is cases of related to claims for silicosis in Victoria State in Australia, and you can see that really they were really quite low until 2019 when they absolutely jumped up, and that was due to a case finding program that was rolled out in Australia, which led to a rapid increase in the number of cases identified. And it was as a result of the scale of the issue identified in Australia that they led to a ban in 2024 of high silica content or silica containing artificial and engineered stone. So the product has now been banned in Australia, but has not been banned anywhere else in the world to date. And then in the UK, so these are cases of silicosis reported to SWORD, which is our national reporting scheme for occupational respiratory diseases, and it's voluntary. So this is again going to be an underestimation of the scale of the problem. This is centres called GORD centres. So these are the specialist occupational lung disease services around the country, and people from non-GORD centres in the blue. And what I really want you to take away is that levels of silicosis, so the incidence reported, has been relatively stable until the last couple of years. And again, this is all attributable to the new cases of artificial stone silicosis that are emerging. So silicosis is diagnosed through a combination of an appropriate occupational exposure history and radiological changes. And broadly speaking, we think about silicosis as being chronic forms of silicosis, which are divided into simple silicosis and complicated silicosis, or progressive massive fibrosis. And the teaching was that these cases generally start to appear minimum of 10 years after exposure, but more likely 15 to 20 years after exposure. And the differentiation between simple silicosis and complicated silicosis is based on the size of the nodules that you see on imaging. So often you can't see simple silicosis very easy on chest X-ray, but when you look at the CT scan, you can see an abundance of tiny nodules, all less than 1 centimetre in diameter. And that gives you the diagnosis of simple silicosis in conjunction with an appropriate exposure history. People with simple silicosis are usually asymptomatic and usually have normal lung function. If those little silicotic nodules coalesce, they start to form masses, usually in the upper zones. You can see here these big white lumps. This is complicated silicosis because the nodules are 1 centimetre or greater in diameter. These patients will have cough, breathlessness, and maybe some chest tightness, and they will have reduced lung function. And in addition, very rarely we tend to see cases of an acute silicoproteinosis, which comes on of much shorter duration and causes a lot of inflammatory change, which you can see here, and it's throughout the lungs, not just located in the upper zones, and indeed you've got some shadowing in the bases here. Generally, this comes on with less than 5 years of exposure and is associated with very, very high exposure to RCS, and historically has been very rare. But when you look in slightly more detail, you find a little bit more information about the other form of silicosis that can occur. And I've just highlighted this here in the bottom. So this is accelerated silicosis, and it comes on between 2 and 10 years after exposure. And it's a rapidly progressive disease. It causes nodules and then masses, which look like progressive massive fibrosis. And people will, with this accelerated disease, will report dyspnea or breathlessness, cough, and will develop respiratory failure. So this is a new sort of, it's not a new classification, but it's not something that we used to see particularly because it was associated with very high exposures. And it's really important to be mindful in this group. So in addition to causing silicosis, silica exposure is also associated with other conditions. So for many years, we've known that it's associated with connective tissue diseases, and these include systemic sclerosis, rheumatoid arthritis, SLE or lupus, and an ANCA-associated vasculitis, so inflammation in the blood vessels. In a case series from Australia, round about a quarter of silica-exposed workers had positive ANA, suggesting they had a connective tissue, that they may have a connective tissue problem. Of these, out of those, 25% were ANA positive, 5% were ENA positive, and 2.6% had rheumatoid factor positive. So round about a quarter of silica exposed workers are going to have a positive ANA. When you then go on to look at the proportion who have clinically signs of clinical connective tissue diseases, the numbers are much lower, but certainly silica exposure seems to drive an ANA response in some people. Silica can cause airways disease, so it can cause chronic obstructive pulmonary disease or COPD, and this is often seen as emphysema. There is a suggestion from data from China that this is more common in people who are artificial stone exposed compared with natural stone exposed. And silica is also known to be associated with an accelerated decline in FEV1 or forced expiratory volume in one second, so lung function decline detected on spirometry. In addition, it's associated with asthma. So there was a prevalence of self-reported asthma in 10% of artificial stone workers in a recent paper from Australia. So it's also something that we look for when we see patients in clinic. Silica has been known for thousands of years to be associated with TB infection, and the combination of silicosis and TB can be very difficult to differentiate between based on radiology alone. So we need to screen patients for evidence of TB or latent TB infection. Silica is a class 1 carcinogen, which means that it is known to cause lung cancer. And so anyone who's working with silica, whether it's artificial stone or natural stones, are at risk of lung cancer and should be warned about symptoms that may develop and should be asked to seek medical attention if they develop those symptoms. So weight loss, coughing up blood or hemoptysis, and increased breathlessness. There's also an association between silica and kidney disease, and so we screen our patients for kidney disease using blood test and a urine dipstick as a very simple screen when they come to clinic. And dermatitis is also caused by silica exposure. So when we see people with silica exposure in clinic, we're not only looking for silicosis, but we're also looking for these other conditions and keeping an eye when we follow them up to see if any of these diseases emerge. So on to the UK. So you've seen the epidemic curves from around the world, and you've seen how those case series have emerged. We had no confirmed cases of silicosis due to artificial stone in the UK until around October 2023. Those first cases were seen in London, and then they more and more have started to emerge. And in September 2024, we published this first UK case series of the cases that we'd seen in the UK to date. So they were all of 8 men with a median age of 34 years and a range of 27 years being the youngest and 56 years being the oldest. 75% of those cases were born outside of the UK and had moved to the UK and started work in the UK as a stonemason, and that's where they'd acquired their exposure. And they had a combination of the simple silicosis, complicated silicosis, and acute silica proteinosis. So that was 2024. Moving on to now, we have between 32 and 38 cases at the Brompton Hospital in London, and there's probably around 5 other cases have been identified in other clinics in the UK. Just looking here on the right, you can see that 38% of those are simple silicosis, 15% are complicated, and almost half have acute or accelerated features on their radiology. So that means that they have been exposed to extremely high levels of RCS that have caused them to develop silicosis. So this is data from 32 of them. You can see that they're all men. The age range is the median's 39 years, but we now have cases who are only 23 years old. Around a third were born in the UK and 2/3 were born outside the UK. Many of them are current smokers or ex-smokers, and I think we have good evidence now that the combination of silica plus being a smoker is detrimental to development of silicosis. And so we really, really strongly support our smoking services, referrals to smoking services, and try and encourage our patients with silicosis or who are RCS exposed to quit smoking. And the duration of exposure in years, so the median is 14 years of exposure, but some have only had 2 years of exposure and others have had up to 53 years of exposure. And that will be to a combination of natural stones and artificial stones. But round about a third of them have only ever been exposed to artificial stone. So for example, some will have been exposed to natural stones for maybe 30, 40 years, but then in more recent time have had 10 or 15 years of exposure to artificial stone, and they're included in this group. This is 32 cases from the Brompton Clinic. They are very, very similar when you look at the data that is coming out of other countries, so Australia, Spain, California. The demographics are very similar wherever you look, and it's really quite striking. This just highlights other features. So unemployment is really high in this group, and that is important not only because it tells you a little bit about their health, but also because it means that these people are financially vulnerable, and they may struggle, for example, to pay for travel up to your clinic appointment. They may be struggling to pay their rent. And many of them are being rehoused out of area because for that very reason. And so, you know, one of the things that we really try and think about when we see people in clinic is to take a holistic view and to talk to them about finance and what sort of support is available. You will see that a small proportion remain exposed to silica and continue to do so, and that is through their own choice. We cannot force people to stop working, and if they are aware of the risks of carrying on being exposed to our RCS and wish to do so, then you know, we don't stop them from doing that. We just make sure they're fully informed. What we do know is that data from Spain shows that if you stop exposure once you're diagnosed with silicosis, 50% of people remain stable and 50% of people will have progressive disease. And so, you know, I have to explain to people, I don't know what's going to happen if you keep being exposed. And I think what I would say is that if you have advanced disease, I really strongly encourage people to stop. What we don't know is about the implications of stopping work if you only have simple silicosis and a few nodules and you're well protected using respiratory protection, like an air-fed respirator, water suppression, local exhaust ventilation. Because for giving up your job has got huge implications for your livelihood, for your family, for your mental health, your physical health. So it needs to be a careful conversation. And I don't think we really know who needs to stop and who should carry on. But we have an informed conversation with patients. I just want to flag up that the kinds of blood pictures that we see are very similar to those that we would see in other conditions like sarcoidosis. So low lymphocyte count or lymphopenia, elevated serum ACE or angiotensin converting enzyme, and a positive ANA in around a third, which is exactly the same as that reported from Australia. And also that in terms of how we're identifying patients at the moment, around 60% come from respiratory colleagues around the country and around London. However, around a third of people are approaching us directly because they are worried about their health because they've seen their colleagues get diagnosed with silicosis and they want to get checked out. And we would absolutely encourage this. And you can see at the top there, Lungs at Work is our umbrella departmental website, which contains information for patients about how to refer themselves to us, and indeed information for other clinicians to access us and to ask us questions and to reach out to us if they wish to do so. The radiology associated with silicosis is very variable, and you'll be able to see that in the next few pictures. So this is difficult because it means that it doesn't always look with artificial stone silicosis, particularly the accelerated and acute cases, like the silicosis radiologists are used to looking for. So conversations need to be had with radiologists about the fact that this is, your patient's exposed to artificial stone. Could this be artificial stone silicosis? So the picture on the left of the screen is a 40-year-old who's had 22 years of exposure, and he's always used a face mask, he says, and he's got quite clear evidence of progressive massive fibrosis. But the photograph of the 27-year-old who's only had 4 years of exposure and never worn a mask has got widespread nodularity, but with a lot of distinct ground glass infiltrate and with some mosaic attenuation. And there's no fibrosis there, and there's no progressive massive fibrosis there. So it's, these look quite different, but are in fact both forms of artificial stone silicosis. And this is a CT scan, which shows a 31-year-old with 13 years of exposure. And you can see that he's got widespread severe silicosis with some bully up at the top and lots of tethering and pleural involvement. And this is advanced silicosis. And he had signs of silica proteinosis when he presented. So now I've got a few cases just to illustrate some points. This is a 24-year-old man who came to us from the TB clinic. He had 8 months of work as a stonemason in the UK and probably a couple of years of natural stone exposure as a stonemason prior to coming. But since he had, prior to coming to the UK, but he was dry cutting and polishing artificial stone, and he was exposed to very high levels of silica, and he had stopped 2 years prior to me seeing him. And he presented to the TB clinic with a 2-month history of dry cough. He had no breathlessness or other respiratory symptoms. He was otherwise fit and well and took no medications. He had a blood panel done, and you can see that his ACE level was very high, iron deficient, lymphopenic, and his ANA was negative. And he had a bronchoalveolar lavage, which showed a high lymphocyte count, suggesting sort of inflammation in the lungs. And this was his CT scan. So he has got a combination of nodules, which are bigger than 1 centimetre, so progressive massive fibrosis, but he's also got those indistinct ground glass changes at the frontal or anteriorly of his lungs with some features accelerated disease. And you can see that his exposure history is 3 years at most. And here is his serial lung function. So he's had 4 sets of lung function done since I met him in September 2024. And it's a bit difficult to see, but what I want to show you and to demonstrate is that this is someone who's no longer exposed, and his lung function has really fallen over that year and did so sequentially. So he's gone from 3.91 litres to 2.46, and it's now about 51% predicted. FVC, again, he's lost nearly 1.5 litres of his FVC, and he's also had decline in his lung volumes and in his gas transfer. So, this is really concerning, and he is at risk of further deterioration and progressive respiratory failure. Had a whole lung lavage performed, and he also had some methylprednisolone to see if that improved things, but unfortunately did not. These were all done between October 24 and September 2025, and neither of those interventions has changed his lung function decline. This is a 32-year-old who presented to the respiratory clinic. And then was referred to us. So he had 8 years of exposure to natural stones overseas and 7 years of artificial stone exposure in the UK. He had onset of breathlessness in 2022, and he was first seen in the respiratory clinic in February 2023, but had a CT just before then. He stopped exposure to RCS around the same time, and he's a lifelong never smoker. He also had some polyarthralgia, and this is his lung function, which you can see, apart from an elevated residual volume suggesting some gas trapping, is otherwise normal in February 23. His blood picture showed lymphopenia, elevated serum ACE level, and he had positive anti-nuclear antibodies in various combinations. So this sort of fits with his polyarthralgia, and he was then seen by a rheumatologist. But unfortunately, his lung function also has declined. So he's lost 2 litres from his FEV1 over just over a year. And again, 2 litres off his FVC and reduction in his TLC gas transfer in that same period of time. So again, really quite rapidly progressive. He had methylprednisolone and was started on mycophenolate for his joints, and he has been referred for a lung transplant. And just to show you, this is the imaging that was performed just before he was seen in the respiratory clinic. And you can see widespread nodular changes, and he has some lymphadenopathy as well in the centre of his chest. And these are the sorts of changes that we often, imaging that we see with sarcoidosis. And unless you'd asked a history about exposure history, then it's pretty much indistinguishable from sarcoidosis. And this is his imaging in July 2024. And you can see, I hope that he has progressed with more consolidation changes, consolidation of those white masses and development of sort of progressive massive fibrosis. So again, he's in trouble with progressive disease despite cessation of exposure. So this overlap between the radiology and the clinical picture with sarcoidosis is a real problem, because it is very much implies that there will be patients around the country who have silicosis but who are being currently treated as sarcoidosis. And this is one chap which provides an example for that. So he's a 59-year-old and he had an incidental finding of bilateral hilar lymphadenopathy after a chest x-ray which was performed for back pain. He was seen in the respiratory clinic. He had spirometry which was normal. His CT scan confirmed lymphadenopathy in the chest. Again, high serum ACE and a low lymphocyte count. His local team felt that he had these were consistent with sarcoidosis, and he had an endobronchial ultrasound biopsy, or an EBUS, which was reported as showing no granulometer. But they didn't look for the presence of birefringent crystals, which are signs of silica crystals, and they didn't look for silica nodules in the lymph nodes. I mean, the word of warning there is that the amount of tissue you get on an EBUS sample is very small, and there's pretty good data to show that you don't see silicotic nodules, and you don't always see birefringent crystals on EBUS samples, and you need to take a bigger sample if you want confirmation that this is indeed silicosis. His only symptom really was arthralgia, and he again had positive anti-nuclear antibodies and connective tissue antibodies when tested. He was a smoker. And due to his symptoms, he was started on oral steroids and hydroxychloroquine by his rheumatologist. And this is a sort of clinic letter, which when you go back, and with retrospect, I appreciate it's very easy, but he was seen, and it says the changes that he had were suggestive of sarcoidosis. And indeed, this is the diagnosis that was in his notes from 2021. And then there is a suggestion that he's unable to do his work because it involves carrying heavy stones. And so there's a clue there about the sort of work that he might do. And then a little bit later, it says that he was reviewed again and that he was able to work regularly on a building site. But nowhere in the clinical history has anyone taken an occupational exposure history. And this is, an ubiquitous problem in respiratory clinics, that we don't always ask about what people do for a job and what they're exposed to. But the local consultant looking after him realised when they started to hear about the case of artificial stone silicosis that this guy may indeed be such a case, and so referred him up to us. And when you spoke to him, he had been a stonemason for 45 years, and he'd worked both in the UK and abroad. But for the last few years, he'd been working with only artificial stone and no respiratory protection. And indeed, this is a photograph that I showed on the installation, and this is him installing a kitchen worktop in people's homes. So he's clearly exposed to very high levels of RCS and has been for some time. And there's lots of reasons why it would be helpful to have the diagnosis up front rather than being treated for sarcoidosis for many years. And that's because steroids don't work for silicosis, and they can cause unnecessary side effects. So there's all the issues to do with diabetes, hypertension, cataracts, osteoporosis, skin thinning, mood disturbance, weight gain, etc. And exposing someone for several years or even several months to steroids when you don't need them or it's not going to work is generally not a good thing. It also means that he wasn't able to be informed about the risks of continuing to work as a stonemason and wasn't given the appropriate advice about financial aspects such as benefits and medical legal claims. And he had never had any occupational health input into his work, so only around a third or so of companies and workers have occupational health input, and therefore he had never had health surveillance carried out. And HSE guidance is that workers who have a residual risk of exposure to RCS should undergo health surveillance on a regular basis, and this includes a combination of questionnaires, spirometry, and chest x-rays at various intervals. And there's some issues around the fact that not everybody who should have health surveillance actually receives health surveillance, and indeed chest x-rays are often not done because people find it difficult to access them or arrange them. And there's ongoing conversations about whether the health surveillance programme needs revising for silicosis and particularly artificial stone workers, which is ongoing in the UK at the moment. So these are pretty bleak pictures, aren't they? And there are very limited treatment options for silicosis and silicosis due to artificial stone. What we do is we provide supportive care. This includes an explanation of the disease and advice about smoking cessation and support if needed, pulmonary rehabilitation and assessment for oxygen assessment. And what I would say is it's very difficult to persuade a 27-year-old to do a pulmonary rehabilitation class, but we download step counters onto their phones. We encourage them to walk their children to school, to pick them up from school and to take them to the park and play football with them, and generally try and keep active as far as possible. We also encourage them to try and maintain their mental health. This is an absolutely distressing disease. There have been deaths from silicosis due to artificial stone in the UK already, and there will continue to do so. And patients become aware of this and they're very frightened. So we try and support their mental well-being as far as we can. We provide them with work and about the risks of ongoing exposure at work and about different alternatives that they might be able to do with their skills. And we provide them with advice about benefits, so they're eligible for industrial injury disablement benefits, and we support them to make claims for that. And they're also entitled to explore a medical legal claim to make a personal injury claim against their employer. If they say that their company has shut down and therefore they won't have a claim to make, it's actually the insurance company that gets sued, and therefore they shouldn't worry about that. But it is really important that they speak to a lawyer who has experience and expertise in industrial injuries and industrial diseases. And there are timeframes around that. So the statute of limitations states that that process must start within 3 years of knowledge that you have an occupational lung disease. So if you write that someone has silicosis in the medical records but don't give them the advice for a few years, either because you're not sure they've got definite silicosis or because you don't want to get to that stage yet, or they don't have severe disease, they may well run out of time under the statute of limitations and not be able to pursue a claim. So we try and give really clear advice to patients about how to pursue these avenues. There have been trials of medical therapy carried out globally. There was some suggestion that steroids might be of benefit, but actually, as time has gone on, that has become increasingly clear that it is unhelpful. Whole lung lavage means that somebody comes into hospital, has a general anaesthetic, and then they have one side of their lung washed out with large volumes, around 15 litres of normal saline, to try and remove the silica. Now, there is some evidence this may result in radiological improvement, so the CT looks better, but there's no change in long-term lung function or in their exercise capacity based on a cardiopulmonary exercise test. And so while some centres will do this, there's no good evidence that it improves outcomes for patients. It's also very invasive. They come in, certainly in the UK, they will come in on one day and stay overnight and have one lung done, and then they will come in on another day and have the other lung done. And we can do this test at the Royal Brompton Hospital and are used to doing it. But as they said, there's no good evidence that it's really going to improve outcomes at this point. There's been some interest in antifibrotics, and particularly in nintedanib. The InBuild study was a study of nintedanib in patients with pulmonary fibrosis. And there was a very small arm, which included 24 patients, which had other interstitial lung diseases, which were not usual interstitial pneumonitis or idiopathic pulmonary fibrosis on CT. And those 24 will have included some cases of silicosis. And the InBuild study showed that there was a decline in this group, which was 79 mils per year in the nintedanib group versus 154 mils per year in the placebo group. But really, building on that, so this sounds encouraging, but building on that, there's been further recruitment for a study in Australia, which has essentially stopped due to lack of efficacy. So there's people aren't really using it, or at least have not seen any real benefit to date. There's also interest in some anti-inflammatories. So under this umbrella includes tetradine, which is a calcium channel blocker, in addition to targeting LIMP2 and causing immunomodulation. And this is in a recent study from China. The results are promising, but we're really waiting to see if the results are replicated in other studies elsewhere. And there's a suggestion that infliximab may be used, but there's an obvious risk with that of recurrence of TB in patients who are already very receptive, at risk of getting TB and reactivated TB due to the association between silica and TB. And finally, there is, so this is all, there's no good evidence as a take-home message, but there is transplant as a final option. The outcomes from series outside the UK suggest that whilst the surgery is more difficult because of all the calcification around the mediastinum, and that the lungs are more difficult to remove, that the longer term outcomes are better than for other conditions like idiopathic pulmonary fibrosis. So transplantation is not a first choice treatment because of availability of organs and the complexities around it, but it is something that we can talk to patients about and refer on cases within Royal Brompton and Harefields Hospitals Trust if they're eligible. So in summary, I hope I've persuaded you that this is a serious preventable disease affecting a young, vulnerable workforce. That there is a real under-recognition of cases, and this is due to lack of awareness, and that's in primary care, secondary care, and by radiologists. The occupational histories are frequently not explored, and patients with sarcoidosis are not asked if they're exposed to stone dust, leading to misdiagnosis, both of sarcoidosis and other respiratory conditions. So you'll see that some of the cases that I reported came from TB clinics, for example. In addition, with regard to the patients, it's asymptomatic in the early stages. So with early disease, people are not going to have any symptoms, and so they won't present to healthcare facilities. And even if they do have symptoms, these are young, they're men, they often don't speak very much English, they're often on 0 hours contracts. And all these factors mean that they're less likely to attend their GP, for example, for a cough or some mild breathlessness. And so, a key thing is that if they do present to primary care, to ask some questions about their job and if they work with artificial stone, because they're unlikely to come back if they're given, for example, a salbutamol inhaler, a course of antibiotics, or come back and see if you've still got symptoms in a couple of weeks' time or a few months' time. They may not come back. I've talked about the current health surveillance programme in the UK, and as it is, it's not going to identify many cases because some of those cases have got symptoms with only a few years of exposure, and many people will not have chest x-ray changes even if they do have the chest x-ray done, because chest x-rays are not very sensitive on picking up disease. And finally, many workers do not have access to health surveillance programs despite HSE guidance. The other thing to say is that health surveillance isn't there to diagnose cases, to find all the cases, but it should help in identifying cases early so that patients can be advised about work early and hopefully reduce the chance of getting progressive disease. Some of the patients who are affected by silicosis have been really, really keen to do everything they can to try and raise awareness of the problem of silicosis in the UK. And actually a media campaign in Australia was really key in identifying lots of cases and getting people to come forward. So here are 3 men from the Brompton Hospital clinic who all made a decision themselves that they wanted to speak to the national media and tell their stories to raise awareness not only for workers but also for healthcare professionals, and to try and reduce the chance of other people going through the sorts of having the sorts of journeys that they have had. I'd encourage you to look up these cases and to read more about them. So takeaway messages: please ask your sarcoid patients about exposure to stone dust. Education and spreading awareness of this condition is key. So please talk to all your colleagues about this, and please reach out to us if you have any questions. There are a number of specialist occupational lung disease services around the UK. These are known as GORDs, but if you have any queries, please get in contact with us through our website and we can signpost you to local services if you're not from the London and South West or South East area. The reason that it's important for patients to be seen in specialist services is so that we can report numbers to the National Reporting Scheme, and we can enter their data onto the UK Silicosis Registry. And this is so important because without demonstrating that numbers are going up, we're not going to be able to have momentum behind the need to try and prevent this disease and to invest in research to understand how we can prevent it. And the UK Silicosis Registry is going to provide longitudinal data from around the UK from these patients, so we can understand patterns of disease, where the cases are arising from, and how best to treat them. We can also provide specialist appropriate advice about work. And as I said, we try and take a holistic approach to that, not just telling people to stop work. It will also allow us to identify colleagues who may also be affected, because we can reach out to other people in the workplace via the patients if they're happy to do so, to try and identify other cases. And we can provide specific support with industrial injury disablement benefit and industrial disease lawyer experts. Final thing is the British Thoracic Society clinical statement on silicosis is currently being produced, and we hope that it's going to be published in 2026, and that should provide a comprehensive overview of the epidemiology, the diagnosis and the management of silicosis in specific to the UK population. I'm just going to finish there by acknowledging the hard work of my team at the Brompton Hospital in this photograph at the bottom, in terms of trying to really drive this agenda forward and look after these patients. As I said, we're at the Brompton Hospital. Our departmental website is Lungs at Work, and there's lots of links on there and information on there about how to get in contact with us to ask about individual patients or about workplaces or about referrals. And I'd like to thank you for listening. Many thanks.